flies to room faster than the sight of a person standing at the microphone, right? You're all like, what's going to happen now? Thank you all for being here this evening to join us. My name is Carol Silver Elliott. I'm President and CEO of the Jewish Home Family, which is the parent organization of the Jewish Home at Rockley, Jewish Home Assisted Living, Jewish Home at Home, and the Jewish Home Foundation. We had embarked on this journey around Parkinson's disease almost 2 years ago, prompted really by a question asked to us by one of the family members of one of our residents in the nursing home. And she asked us a very simple question that led us on what has become a fairly profound journey. And she said, why is it that you treat my husband as if he has dementia when what he really has is Parkinson's disease? And it was an eye-opening moment for us when we realized that our staff and we were assuming that this gentleman's communication issues was because he had a cognitive impairment, but what he had was a slowness in his speech that we were not giving him time to fully use. And we began to look at what Parkinson's disease meant to us as an organization, finding out that 10% of our patients currently have a diagnosis of Parkinson's disease, beginning to realize that there was much more that we could and should be doing for individuals with Parkinson's. We were very fortunate early on in this journey to get in touch with and have meetings with the Michael J. Fox Foundation, who helped us to crystallize the kinds of programming that we could do. We began to work with the Fox Foundation to help them with community outreach. They have helped us with the community education, and this is the second program in that series, the second one actually in this very room. We've worked with them to understand what the clinical benchmarks are, who's doing groundbreaking work, what are the things we should know about, and over the course of time have been able to expand our treatment modalities to include all kinds of new things, including yoga for Parkinson's, and Tai Chi for Parkinson's, and dance for Parkinson's, and a community support group, which is really the first in our part of the county. And we've added a very robust program for Rocksteady Boxing. If you didn't learn about Rocksteady, there's still materials out there. But Rocksteady is a program we've added both in the nursing home for our residents and for our community in our Jewish Home Assisted Living site in Rivervale. We've recently added a brand new specialized day program that is part of our Gallon Adult Day Center that, again, is focused on individuals with Parkinson's. It's become part of the definition of who we are as a Jewish home family, and we continue to look for new ways to expand our knowledge and our services, providing not just care for a disease or a specific body issue, but comprehensive care for an individual with Parkinson's and their family. I'm thrilled tonight that we have Samantha Hutten with us. Samantha joined the Michael J. Fox Foundation in 2014. As Senior Associate Director of Research Programs, Samantha stays closely linked to the Parkinson's community in order to develop an aggressive and innovative agenda for accelerating research and drug development for Parkinson's disease. This ensures that Fox Foundation priorities reflect and best serve the ultimate needs of patients. Samantha regularly meets with academic and industry scientists around the world to identify promising ideas to support providing troubleshooting and ongoing management of projects as they go forward. Samantha currently manages the Foundation's efforts to develop biomarkers of Parkinson's disease, critical tools for the development and testing of promising Parkinson's therapies. Samantha graduated from Vassar College with a BA in Neuroscience and Behavior and received her PhD in Biomedical Sciences from Albert Einstein College of Medicine. Prior to attending graduate school, Samantha worked in the biotechnology sector at Psychogenics, where she tested drug treatments for Parkinson's disease. Here's the little-known fact. Samantha attended high school right here in Englewood, New Jersey. She will be speaking for about 40 minutes, and then we will be joined by a couple of additional panelists, Dr. Harvey Gross and Dr. Ricky Rosella, whom I will introduce at that point. We'll have an opportunity for questions for the panel for about 15 minutes. So without further ado, Samantha.
okay? All right. Let's see if this works. Well, thanks so much for having me, and Carol, thanks for the kind introduction. I'm really excited to be here today talking to you about what's new in Parkinson's research, and I'm happy to answer any of the questions that come up on the panel afterwards. So I thought I would start out with just an overview of the Michael J. Fox Foundation, and who we are and sort of what we do and what we stand for. So the Michael J. Fox Foundation is the world's largest nonprofit funder of Parkinson's disease research. And we were very fortunate when Michael started the foundation in 2000 that there were other groups working on patient advocacy, patient engagement, and patient support, which meant, at least at that time, that we could focus all of our efforts and all of our money 100% for research purposes. So our agenda has always been to really aggressively fund research to improve the current available treatments for Parkinson's disease and ultimately find a cure. And Michael always jokes that he wants us to go out of business, and that's our business model, is to spend the money and go bankrupt, because that means that we have successfully cured Parkinson's disease. So there's about 150 of us in our New York City office, and our donor services group, just fun fact, last year alone processed 93,000 donations. And what that means in practice is that we were able to fund $100 million in research last year. I think we're tracking to spend even more than that this year, so it's a really exciting time for us to be able to deploy those resources. To date, we've spent almost $800 million directly towards funding scientific research to understand the biology of Parkinson's disease and to develop new therapies and treatments for people living with the disease today. So I should mention that we fund academic groups, we fund industry groups, biotechs, pharma. We don't care who we're giving the money to, as long as it's the best science and it's the science that the field needs right now. So that science that we fund is sometimes in the United States, and oftentimes it's abroad around the world. We have investigators in Israel, in Hong Kong, Australia, Europe, everywhere that you can imagine. We have funded somebody if they're doing cutting edge science. So I also wanted to highlight that we actually do now have a patient advocacy group with the dissolution of PAM, which was the Parkinson's Action Network. A few years ago, PAN actually came under our umbrella, and last year alone, our advocacy team spearheaded 54,000 emails that went to Congress about issues that are relevant to Parkinson's disease and people living with Parkinson's disease, around FDA approvals and drug engagement and insurance issues. So really cool to be part of this organization, and really happy to be here to tell you a little bit more about what we're doing. So our strategy has always been, we like to think of ourselves as spending the money smarter, and what that means for us is we're constantly surveying the field, figuring out what the unmet needs are, and figuring out how the precious donor dollars that we receive can make the most impact. So we don't have an endowment. Every year we raise our money, and every year we send all of that money back out the door, because we're hoping that the next year is the year that we close down because we've solved the problem. So this year we evaluate our priorities every quarter. The scientific team has a powwow, we put our heads together, and we figure out exactly where we need to spend the money, and specifically how we can figure out what the unmet needs are in the field towards driving that research. So we're very fortunate, thanks to the generosity of our donors, we are able to deploy 89 cents out of every dollar that's raised directly to scientific funding. So we like to say that we know science, but we also know the business of science. So this is reflected in our research programs team, which includes, this should say, I think the numbers are a little messed up, it should say 11 PhDs, 1 MD, and 12 business strategists. So I'm one of the PhDs on staff. But we also have our in-house doctor and a whole host of people with MBAs, and this marriage of business and science helps us to keep things moving in a way that is urgent and nimble, so that we can shift our priorities when we need to. And we'd like to really maintain this sense of urgency and take it as we feel it from our donors, and then instill it upon the scientists that are receiving our funding. So you may be familiar with other funding organizations, for example, the National Institute of Health. If a scientist applies for funding, oftentimes once that funding is received, that scientist will then check back in at the end of the grant period and say, this is what I did, this is the question that I had, and this is how I went about solving it. We operate a little bit differently because we really want to maintain that constant contact and hold our scientific awardees accountable. So we check in with them often, and we release our payments in stages so that as they're meeting scientific milestones in much the same way a business agreement would be structured, we release payments that are in line with the work that they've done. So that allows us to really be thought leaders and partners in the research endeavor, but it also allows us to course correct so that if something goes wrong with a particular grant or that scientist needs a little bit of extra support, we can utilize our network of other scientists to help really solve that problem. So this marriage of business and science seems to be working well for us, and it enables us to really instill this accountability forward onto our scientific awardees. So now that I've told you a little bit about the Fox Foundation, I'll just give you some background on Parkinson's disease. Parkinson's is the second most common neurodegenerative disorder next to Alzheimer's. It affects roughly 1 in every 100 people over the age of 60, and there are roughly 60,000 new cases identified each year. So I've read a paper recently where this number was projected in 2040 to be around 14 million. So the number is continuing to increase, and this could be for a lot of reasons, but we're living longer as a population as we're solving these other diseases. We're increasing our lifespan, and I think this only serves to sort of fuel the urgency that we feel for finding a cure for this disease as soon as possible. So I'm sure I don't have to tell the people in this room, oftentimes patients come to us and they say the road to diagnosis was really difficult. It took me a long time to figure out what was wrong and to figure out what doctors I should be seeing and how to set up my care team. This could be a lot of times because symptoms can be confused with other neurological disorders. Sometimes symptoms are masked by normal aging. Sometimes they can be mistaken for a sports injury. A lot of times we also hear people say, no two cases of Parkinson's disease are alike. My Parkinson's is totally different from this person's Parkinson's disease. And that is, again, one of the really tricky challenges of dealing with such a heterogeneous disorder. Also, there's no objective test for Parkinson's disease. You can't go to the doctor, stick out your finger, get a finger prick, and have them say, yes, you have it, or no, you don't. And that's really different from some of the other disorders or even common conditions. If you want to measure your cholesterol, you go and you give blood, and there's a cutoff. They say, if your cholesterol is over this amount, you have high cholesterol, you have to watch your diet. And if it's under that amount, you're in the clear. So having something objective like that with respect to Parkinson's disease would really be a game changer, and we spend a lot of our effort and our time and our research dollars towards finding that marker that can help us to identify people with Parkinson's disease and track their disease progression, and I'll talk more about that in a little bit. Also today, doctors are diagnosing Parkinson's disease with a clinical exam. That can be a little bit subjective, as you can imagine. Different doctors around the world may be doing things a little bit differently, as much as there are efforts to standardize. So that's another reason why it would be great to have an objective, quantifiable numerical number that would say yes or no whether you had Parkinson's disease. And oftentimes people aren't fortunate enough to be able to have access to or to know that they need to be seeing the right doctor, which is a neurologist and a movement disorder specialist. So for all these reasons, sometimes it can be really difficult to diagnose Parkinson's disease. So now I want to sort of preempt a question that I get a lot. Well, what causes Parkinson's disease? What causes this heterogeneous mixture of symptoms that's so different between different people that have the same umbrella disorder? So I like to think of it as a continuum where on the one side you have genetics and on the other side you have environment. Typically most people tend to fall somewhere in the middle, which is a nice way of saying we don't really know. But there are definitely environmental factors that can absolutely lead to Parkinson's disease, and there are genetic factors that can predispose somebody to Parkinson's disease. And figuring out sort of what the mix is and how some people with genetic mutation do go on to develop Parkinson's disease and others don't is one of the major research questions that we're trying to address. So to hone in a little bit on this environmental factor question, researchers have done a lot of work trying to identify through epidemiological studies whether there are specific chemicals and pesticides or solvents that can lead to Parkinson's disease. You might be familiar with the story in the 1980s of the heroin addicts in California who actually received a bad batch of heroin that had one of these substances called MPTP in it. And those addicts actually went on to develop Parkinson's disease, which caught the media's attention, but it also caught the scientific community's attention, because through that mechanism we actually learned that we can induce Parkinson's disease in animal models and in petri dishes just by using this chemical, which has really changed the way that we have done research in the field. So that's an example of an environmental factor that can cause Parkinson's disease. I should mention that all the things that have been identified to cause Parkinson's disease that may have existed before in cleaners and solvents, exposure to metals, all these things are much more regulated now, and certainly not still marketed in everyday products. So I don't want to give the impression that if you're an avid gardener or you once worked with metal that you are predisposed to develop Parkinson's disease. Even with this exposure in large-scale epidemiological studies, there's an association, but it's not causative. It doesn't mean that just because you've been exposed to something, you are definitely going to develop Parkinson's disease. But these things can certainly take a toll, and if you think about that continuum that I mentioned before, it can sort of help us to understand why some people with genetic predisposition may or may not also be affected by environmental or lifestyle changes. On the other end of the spectrum, environmental factors can also be protective. So scientists are also researching things about the environment that enable people with exposure or with genetic mutations to remain disease-free. There are studies looking at anti-inflammatory medications which have been associated with protection from diseases like Parkinson's disease, as well as nicotine. So it's important to remember that while some of these things can definitely correlate or be associated with increased risk for Parkinson's disease, there's also things that can decrease your chances of potentially getting Parkinson's disease, and all these things are things that people are studying in the research field. So you probably remember from biology class that when we're talking about genetics, we're talking about DNA. Our genes are all contained in our DNA, and our DNA is like the instruction manual for making proteins. Everything that happens in our body is dependent on proteins. So if you have a DNA mutation or a genetic mutation, that mutation leads particular proteins to not be made correctly. And when you have incorrect versions of those proteins around in your body, it can lead to physiological consequences and diseases like Parkinson's disease. So there are certain genetic mutations that are associated with Parkinson's disease. I've listed some of them here, and they all have different degrees of risk associated with them. So roughly 10% of Parkinson's cases can be thought to be attributable to genetic factors. Some of the high-risk genetic mutations, for example, one of them is alpha-synuclein or SNCA. So this is a very high-risk mutation because if you do have it, your chances of developing Parkinson's disease are much more common or more likely, but there are literally 100 people in the world that have this mutation, so there's high risk, but it's very rare. There's also other mutations that are associated with Parkinson's disease that carry a little bit more risk, not as much as alpha-synuclein, for example, but are less rare. And those are the leucine-rich repeat kinase 2, or LRRK2 mutation, and the glucocerebrosidase, or GBA mutation. So again, these are a little bit more common in the population, but just because you have one doesn't mean you'll go on to develop Parkinson's disease. In fact, out of all the people that have Parkinson's disease worldwide, only 3 to 6% of those patients have a LRRK2 mutation, and between 2 and 5% of those patients have a mutation in the GBA protein. So all this to say that genetics can predispose people to have Parkinson's disease, and certainly family histories can sort of play a role and impact in determining risk factors, but even if you have twins and one of them has a mutation and one of them doesn't have a mutation, we're still trying to figure out why one of them might develop Parkinson's disease and the other one might not. So this is how lifestyle and environment and genetics can all come into play together, and we're still trying to parse that out and figure out exactly how we can determine why some people get it and some people don't. So these are the two mutations that I was just talking about. These ones are more common in people of Ashkenazi Jewish descent. For the LRRK2 protein, I like to highlight this as an example because when you have a mutation in this protein, it causes the protein to be too active. So there's a drug treatment right now that's actually being tested in phase 1 clinical trials where they actually dampen down the activity of this protein, because if it's working too hard, we want to give an injection or a drug that can keep it at normal levels. So that was really exciting for us because it was one of the first ways that we could potentially treat or target genetic populations of patients that might especially benefit from a particular treatment that has a disease-modifying effect and doesn't just treat the symptoms, but treats the underlying cause of the disease. Likewise, mutations that lead to malfunctioning GBA or GK protein, on the flip side, cause that protein to not function correctly and to not have enough activity. So there are drug treatments now that are in the clinic that are enabling that drug to work more properly by helping it get to where it's going in the cell and helping its activity to increase, since when you have the mutation, it's not working well enough. So one other thing that I wanted to mention here that I think is important to remember is that these proteins, when they're not functioning correctly, or if somebody has a mutation, aren't just associated with Parkinson's disease. Some people have LRRK2 mutations and they can be predisposed to have inflammatory bowel disease, which is totally separate. Some people with GBA mutations, a lot of people with GBA mutations actually have Gaucher's disease, which is a lysosomal storage disorder. So just because you have a mutation doesn't mean that you're going to get Parkinson's disease. It could mean that you're totally healthy. It could mean that you might have one of these other disorders, but again, the numbers are still really low. Only 10% of people with Parkinson's disease have Parkinson's disease that can be directly linked to a known genetic mutation.